Start. So shall we start?
Yeah, go ahead.
Good afternoon to one and all present here, and a very warm welcome to your favorite channel in understanding cancer, Cancer Reach. Cancer Reach is an initiative by our very own oncogenius Dr. Krishnamani to spread awareness about the cancer and help patients and caregivers access the right treatment at the right time. Without much further ado, let me introduce our tumor tamer to you so he can enlighten us on today's topic, that is esophageal cancer. Dr. Krishnamani is a renowned medical oncologist with expertise in both solid and hematological malignancies. His commitment to advancing the field of oncology is further demonstrated by his membership in American and European oncology societies. In addition to being a full time clinician, he also has a keen interest in research and has participated in multiple clinical trials. Currently, he is working at American Oncology Institute in Hyderabad. A very warm welcome to you, sir.
Hello, thank you so much. And as always, welcome to Cancer Reach, which is an initiative to spread awareness about cancer.
So, sir, shall we begin with today's topic, that is esophageal cancer?
Yes, please.
So, can you tell me more about what is esophageal cancer?
See, what is esophagus? Esophagus is your food pipe. So, esophagus starts from where the pharynx, we say, from where the pharynx ends, that is behind the mouth, and it ends at the stomach. So, basically, the food pipe. That is called the esophagus. So a cancer which starts in the esophagus is the esophageal cancer. It's a food pipe cancer. That's all, very simple.
Sir, what causes the cancer in the esophagus?
So what we should understand is the esophagus anatomically is divided into three parts: upper, middle, and lower, or cervical, which is neck, thoracic, and abdominal. Cervical esophagus is in the neck, thoracic is here in the thorax, abdomen is in the tummy, or upper, mid, and lower. That is an anatomical classification which is useful for making treatment decisions like surgery or radiation. When you do a biopsy, esophageal cancer can be a squamous cancer or an adenocarcinoma. Okay, so squamous cell carcinoma is one type, adenocarcinoma is one type. This is the broad thing. Now, what causes esophagus cancer? Smoking is a very important cause of esophagus cancer. 40% or 30 to 40% of esophageal cancers can be attributed to smoking. Tobacco chewing, pan masala, zarda, they can add to esophageal cancer. Alcohol increases the risk. If you smoke and also have alcohol, the risk is higher. If you smoke for a longer period of time, the risk is higher. If you start at a young age and smoke more packets of cigarettes for a longer period, the risk is higher. So the longer you smoke, the earlier you start. If you don't stop, the more you smoke, alcohol added with smoking, tobacco chewing, etc. Age. It is a disease commonly seen in above 60 or 70-year-old people, but we also see youngsters nowadays. Obesity. Patients who have a very high body mass index, who are very obese. What happens is, the theory is the lower esophagus, which is here, it has a opening called a sphincter. Okay, it allows things to go down into the stomach. Sometimes acid from the stomach gets into the lower esophagus because when you're fat, the lower esophageal sphincter is laxed. It is relaxed and it is lax. When it is laxed, acid keeps coming up, and that can cause esophagus cancer. A disease called Barrett's esophagus can lead to esophagus cancer. Barrett's esophagus is the lining cells in your food pipe, they change from normal cell to cancer cell. And another disease called achalasia cardia, where what happens is, if your esophagus doesn't move. There's some nerve problem in your esophagus. The food remains in the esophagus. The esophagus becomes big in size rather than the normal tubular structure. That can sometimes lead to esophageal cancer. So these are the broad types, but more importantly, smoking, alcohol, obesity, Barrett's esophagus. These are the common reasons why one develops esophagus cancer. Histologically, it is of two types, squamous and adenocarcinoma. Anatomically, it is cervical, middle or lower esophagus, or thoracic and abdominal esophagus.
If one of the parent, either the mother or the father, has had or had esophageal cancer, is it true that the offspring will also be affected with esophageal cancer in the later stages?
It is not a commonly seen genetic cancer. So when we talk about, you're alluding to genetic cancer, we should think of breast and ovarian cancers commonly, not esophagus. Yes, some syndromes may have, but the common public should not think that my father had esophagus cancer, so I'm going to. That applies for hereditary breast ovarian cancer syndromes.
And what would be the common signs and symptoms for esophageal cancer?
So what happens is these patients come with a history of difficulty in swallowing. It starts with solids. They say, I'm unable to take solid food. And slowly they say, this has become worse, and now even liquids are not going inside. That is because if this is the lumen, esophagus, slowly the growth is blocking and food is not going. Then, because there is low food intake or food is not going in, what happens? They are hungry, but they are unable to take because it is blocked. They may feel a sense of fullness in the chest or the neck. They may have vomiting. Undigested food may just come out. And because there is no intake, they become, they lose weight. So weight loss is very common. They become cachexic. They become very thin. And so these patients or stomach cancer patients come with significant weight loss. So dysphagia or difficulty in swallowing for solids, progressing to liquids, weight loss, vomiting sensation. These are the commons. If the disease spreads to this lymph node, patients may sometimes say that I have a lump in my neck here. If it spreads to the lung, they may come with breathing difficulty. To the liver, they may come with jaundice. Goes to the brain, they may come with headache or fits or seizures or weakness. So these are all, but commonly it is difficulty swallowing. And by the time a patient comes to you with difficulty in swallowing, usually 60 or 70% of the esophagus is already blocked. That's why these diseases, once symptoms come and you rush also, even by then it is advanced. Because there is no way to know in the initial stages. You can't keep doing an endoscopy every day on yourself. So by the time you develop symptoms and go to a doctor, usually this disease is so bad that it is usually advanced.
And sir, like the patients come to you only at an advanced stage, but are there cases where it is being diagnosed even in the early stages? And what percentage would that be if it is
Maybe
diagnosed
less
in
than
early
10, 10,
stages?
less than 10%. How would you diagnose them? Suppose you have some acidity symptoms, you go, you get an endoscopy done. They say, yes, you have gastritis, but you have also a small lesion in the esophagus. We have picked up. That is incidentally detected. You go for something, something else is picked up. That
Okay.
chance is very small, even in the developed world, or even in the metros here, where people are aware. So there is no routine screening test for esophagus cancer. Screening test means something which you should do in the general population to detect the cancer early. There is nothing like that.
And so, what about the diagnostic tests for esophageal cancer?
Always, we have discussed, tissue is the issue. You need tumor tissue. You need to see the tumor cell under microscope by the pathologist and then only confirm cancer. How will you do? Do an endoscopy. It's a small tube with a camera which goes inside. Where the tumor is, they take a small piece, they send it for testing. So endoscopic biopsy, that will tell you if it is cancer, if it is squamous or adenocarcinoma. Then you need staging. So endoscopic ultrasound helps you stage the nearby areas, whether it has spread through the wall, whether it has gone to nearby lymph nodes. Then you need staging to different areas like major organs. That you will do with a CT scan or a PET scan. So you will do an endoscopy, a biopsy in the same sitting to prove your diagnosis, to prove the type of esophagus cancer histologically. You will do an endoscopic ultrasound for loco-regional spread, whether it has spread to the lymph nodes, etc. And you will do a CT or PET scan to see if it has spread to distant organs. This way, you are going to diagnose and stage the cancer.
And so, which is the most common site to where the cancer spreads from the esophagus?
Liver. It goes to nodes. Liver is a common site.
And
Bone and
so,
lung are common sites.
okay. And sir, am I right if I say that if the patient has come in advanced stages, they would all have some of the other metastatic sites also?
Advanced means metastatic or inoperable or recurrent disease which has come back, or in our simple word, stage 4 disease, that is, it has spread to other organs, where systemic therapy is the only treatment, and where treatment is for palliation, which is improving your quality of life and prolonging your life. It is not for cure.
So, can you tell me more about the systemic therapy for advanced esophageal cancer?
So, what is systemic therapy? A therapy which works all over the system, generally given through blood. So, a drug or something given through blood which goes all over your body and controls the cancer. In esophagus cancer, systemic therapy is either chemotherapy or immunotherapy or both. So, once you do a biopsy, you will do certain tests on the biopsy, which is called HER2, MSI, PDL1. These are done in stage 4 or advanced cancers. After the biopsy, do HER2 testing, MSI, PDL1 testing. So you will say you have stage 4 cancer. You need to, if the patient is in reasonably good fit condition, it's an advanced cancer which is not curable. The intent is palliation, which is quality of life and prolonging your life. We'll start you on chemotherapy, which is anti-cancer drugs given through the blood, usually given once every 2 or 3 weeks for 4 to 6 months. Midway, you will do a PET CT or a CT. If the disease is coming down, the medicine is working, so you will continue the medicine for another few cycles. This chemotherapy can cause side effects like hair fall, nausea, loss of taste, vomiting, and weakness. Fall in hemoglobin, fall in WBC, fall in platelet, which you will manage with gargles, anti-vomiting medications, growth factor injections, etc. So basically, advanced stage 4 disease, giving chemotherapy via the blood after 4 or 6 cycles scan, and if the disease is responding, another 4 or 6 cycles. This chemo is given every 2 or 3 weeks. Parallelly, the tumor is also sent for HER2, MSI, and PDL1. If you are HER2 positive, on the chemotherapy, you have added a drug called trastuzumab, which is given in breast cancer. If you are MSI or PDL1 positive, you are added immunotherapy. By adding any of these drugs on chemo, the survival increases. And the advantage is chemo cannot be given continuously. You have to stop it at one point. Patient becomes very weak. After that, what? So after that also, to keep the disease under control, these medicines help. That is your targeted and immunotherapy. It pushes the disease away, if we have to put it very simply, controls it for a longer period of time, gives the patient a chemo-free interval. Without chemotherapy, the patient is on some therapy for some time so that he or she recovers from the chemo side effects. Got it? And the story continues. After that, you will scan the patient every 4 or 6 months. If symptomatically he is deteriorating, disease has increased on scan, then you will change to another set of treatment if the person is fit. Why I say fit is, see, it is a cancer of the food pipe. It interferes with your nutrition. So your treatment is also causing side effects. Your disease is also preventing you from eating. So these patients lose weight significantly with a very short period of time. So nutrition is a key concern. Anybody taking care of esophagus cancer patients should understand that nutrition is the most important thing. Secure nutrition, if the patient is taking orally, well and good. Otherwise, we put a tube through the nose called a Rice tube. If that is not being passed, we put a tube called a pegged tube in the tummy or a feeding jejunostomy or a tube in the intestine. Because feeding cannot be compromised. Once nutrition is taken care of, you will take care of treatment of the disease with chemotherapy plus or minus targeted or immunotherapy. This is how you should approach a stage 4 or advanced esophagus cancer.
Sir, these treatment options are for a fit patient. What if the patient is unfit? Then how would we proceed with it?
So unfit means, I'll put it in very, suppose imagine somebody is bedridden, unable to get up to the washroom also, not able to take a morsel of food also. Those patients are not candidates for chemotherapy. You should not give chemotherapy and they should not suffer chemo-related side effects because the risk will be higher and the benefit will be much lower. So they are candidate for something called best supportive care or tender loving care. You should keep, I'm not, so nobody is saying that you're going to condemn those patients. You're going to take care of them. You're going to take care of their nutrition. If required, give them some glucose or saline bottles. Take care of their pain. If they have severe pain, the pain has to be controlled. But chemotherapy is not an option. Don't think that chemotherapy is only option for any cancer. Not giving chemotherapy helps these patients so that their quality of life is better. They don't get vomiting, nausea due to chemo. They don't develop severe side effects. So these patients should be taken care of so that they don't develop bed sores, their pain is under control, feeding is taken care of, they don't develop low sugars, and basically their quality of life is intact.
Sir, how would you describe the prognosis for a fit patient? And the same question for an unfit patient.
So imagine somebody is bedridden with esophagus cancer or massive liver mets. You are not able to give any form of systemic treatment. Survivals are usually in days or months. If you don't treat somebody also, survivals are less than 3 or 6 months. If you treat, survival may go up to maybe 1 month, 1 year, or slightly more than. Certain varieties of esophagus cancer, like MSI high, if they respond to immunotherapy, longer survival have been seen up to maybe 2-3 years also. But overall, understand it's a bad disease, poor survival. Even if you treat, if you don't treat, survival is much lesser, but the quality of life also suffers. Patient goes through a lot. So your aim of chemo is not just improving the survival, it's also improving the quality of life.
Okay. So the prognosis will not be very good for an unfit patient, but even for a
Not at
fit
all.
patient, it would not matter significantly.
It will not matter significantly in the form of years. It
Yes.
is not like a lung cancer, which is EGFR positive, ALK positive, or a breast cancer, hormone positive, HER2 negative, where they live for 3 years, 5 years, or more. Most patients in esophagus cancer don't live that long. 1 year, 9 months to 15 months is what is their usual survival. But again, what we tell our patients is, don't play God. We are nobody to say survivals of anybody. This is a figure which is quoted, which we see as per our experience. Our aim, so survivals can be individualized. One patient may do well, one patient may not do well. Many factors influence survival. Our aim is survival is a secondary part, the quality of life is a primary.
And since swallowing is going to be an issue with these patients, while the fit patients are on chemotherapy or any other treatment, then how do you maintain the nutrition? How do you explain them to maintain their diet for such patients?
So many of the time they can only probably tolerate orally a liquid diet or semi-solid diet. If they are not losing weight, that itself is a good sign. Many of our patients take protein shakes, they take kanji, they take dal soup, they take bone soup, they take mashed vegetables or curd rice, mashed dal rice, and all. If oral intake is compromised, you put a Ryle's tube or a PEG tube, as I told you, and you feed through.
And sir, for unfit patients, we would be completely giving only through the Ryle's tube.
Ryle's tube, or if you cannot place a Ryle's tube, at least you'll put them on IV fluids or total parenteral nutrition, we say. That is few packets of nutrition that cannot be kept every day, but these are only a temporary phenomenon so that they are a bit comfortable.
Sir, how do you counsel the patients to stay strong during the treatment? Because already the prognosis itself is a bit weakening kind of a statement for such patients.
So, see, it is difficult for a patient because they go through a lot of suffering, lot of pain. See, it is a basic, see, food is a human need, right? So, that part, if you have a cancer in the finger or a hand, I may seem gross, but even if you cut it off because the tumor is in the hand and you need to do a surgery, it is not going to interfere with your intake or your breathing. Anything in the oral cavity, in the food pipe, in the stomach is terrible. So you have to counsel them, you have to motivate them, you have to find a way to feed. So today we have a lady, it's in the upper part of the esophagus, it is completely blocking the inlet. We are unable to, the endoscopy, thin guide wire is not going inside. We are planning radiation for her, it is not spread anywhere. The problem is she is unable to take a drop of water. Radiation to this part of the esophagus to start working, it may take weeks. She cannot live without a drop of water for weeks. So you did it. They tried to do an endoscopy. Nothing is going inside. The guide wire is not going inside. Only the guide wire goes, you can put a tube inside. So there's no chance of feeding. So they're going to put a tube in the intestine temporarily so that we have some feeding at least for this woman. The bottom line is we have to counsel, we have to motivate, we have to sit with them multiple times. Nutrition is a concern, pain is a concern. And overall, in advanced cases, they shrink in front of your own eyes. A person who is reasonably healthy becomes skin and bone. Family suffers a lot. I'm not talking about the financial implications. Getting in and out of the hospital. Rice tube may get blocked, rice tube may get removed accidentally. To place it is a big challenge. You may have to place it endoscopically. The family goes through a lot, and the patients obviously. So, and all through knowing that you are dealing with a bad disease. If you deal with all this and you have a conclusion at the end that you have a wonderful disease and you'll be cured forever, that's a different question. Anybody will be ready to take it for 3-4 months also. Chalo, it's okay. I will bear this for 3-4 months. But the unfortunate part is the end is also not long. The end is short rather. Longevity is short. But that's the nature of the disease. That's how you have to. That's the nature of the job. That's the nature of the disease. So we have to help them out because if we don't help them, nobody's going to help.
Any message for caretakers of such patients or for the patients themselves?
No, the message is simple. To uh, if I have to wrap up things, it's a bad disease. Presence in an advanced stage. Avoid tobacco and alcohol, please, so that you can prevent it in most cases. If you get the disease, nutrition is important. Histology, biopsy is extremely important. Advanced cases do HER2, MSI, PDL1. Who knows? Immunotherapy for MSI patients does well. Chemo is the backbone of treatment. Pain control, nutrition, quality of life is important. Don't lose hope.
Okay, sir. Sir, any last message from you for our viewers today?
Well, that's what I just wrapped up. So, uh, this is advanced esophagus cancer is also treated on the similar lines like advanced stomach cancer. That is one thing I would like to add. So both of them in advanced cases are treated similarly. Yeah. So The only thing is to keep reiterating again and again, quit tobacco, quit alcohol in all forms, including cigarettes.
Okay, sir. Thank you.
Thank you so much.
So we